Welcome to the Deep Dive. Today we're tackling a really crucial topic for your MSRA revision, lumbar spinal stenosis. Think of this as your focused strategy session. We'll use your notes to build a really solid understanding.
Exactly.
Crystal clear insights, ready for recall.
Absolutely. And we want to go beyond just listing facts. It's about connecting the dots, making it memorable, so it sticks for the exams. We'll cover everything, from the basic definition right through to management and what to expect.
Okay, great. So let's start with the basics. In simple terms, what actually is lumbar spinal stenosis?
Well, think of it like this. Your spinal canal in your lower back is like a highway for your nerves. Lumbar spinal stenosis is basically a narrowing of that highway.
And narrowing.
Yeah, and that narrowing puts pressure on the nerves traveling through it.
And that pressure causes the symptoms.
Right.
Like traffic jams on the highway.
Exactly. The main things people complain about are pain, numbness, and sometimes weakness, usually felt in the lower back, but very often it shoots down into the buttocks and legs. That leg symptom is a big clue.
Okay, so what's causing this narrowing? What's physically happening in there?
So the central canal itself can get narrowed for a few reasons. Sometimes it's things like spinal tumors or maybe a disc that's bulged out, herniated. But honestly, the most common cause, it's just wear and tear. Age-related degenerative changes in the spine.
Right, the degenerative side. You mentioned claudication-like signs in the notes. That sounds like vascular claudication, but you're saying it's different. That feels like a key exam point.
Oh, absolutely key. Patients often get leg pain that worsens with walking or standing, which, sounds very much like vascular claudication. But here's the clincher, the real giveaway for stenosis. The pain is typically relieved by sitting down or leaning forward. That forward flexion opens up the spinal canal space a bit, giving the nerves some breathing room. Vascular claudication usually just gets better when you stop moving, regardless of posture.
Got it. So maybe a mnemonic like flexion favors stenosis.
Flexion favors stenosis. Perfect. Remember that.
So it's mainly the lower back, the lumbar region, but can other parts of the spine be involved too?
Yeah, good question. While lumbar is our focus, the cervical spine, the neck, is also a really common site for stenosis. And interestingly, older people who have lumbar stenosis might also have stenosis higher up, like in the neck or mid-back. That isn't even causing symptoms. It can be silent.
Part of a bigger picture then.
Often, yes. Part of that general age-related change.
Okay, definition covered. Let's dig into the why a bit more. What are the main causes, the etiology?
Well, as we said, top of the list is those age-related degenerative changes, just the spine aging, really.
Yeah.
But other things definitely contribute. A herniated disc, where the soft center pushes out, that can narrow the space.
Right.
Also, the ligaments in the spine can thicken up over time, particularly one called the ligamentum flavum. It takes up space.
Ligaments thickening, okay.
And bone spurs doctors call them osteophytes. Little bony growths often linked to arthritis. They can grow into the canal too. Less common causes, things like spinal tumors or maybe a previous spinal injury.
So a mix of gradual stuff and maybe more specific events. Who's most likely to get this? What are the big risk factors?
The biggest one, hands down, is getting older. Advanced age. It links directly to those degenerative processes.
Makes sense.
Also, if you've had spine injuries before, that increases your risk. Genetics might play a role for some people too. And then there are certain medical conditions, osteoarthritis and rheumatoid arthritis are big ones, as they directly affect the joints, including those in the spine.
And there were some less common risk factors mentioned. Good to be aware of, I guess.
Yeah, definitely. Things like degenerative arthritis specifically affecting the spine joints. Some people are actually born with a narrower canal that's congenital narrowing. Then you've got conditions like hyperparathyroidism, Paget's disease of bone, even things like ankylosing spondylitis or endocrine stuff like Cushing's syndrome and acromegaly, less common, but they're on the list.
Okay, quite a range there. So let's get into the mechanics, the pathophysiology. How exactly does the narrowing and the nerve compression happen step by step?
Right. So the core problem is that reduced space in the spinal canal. That squeezes the nerves, or in really bad cases, potentially the spinal cord itself, though that's less common in the lumbar area. This narrowing is usually the end result of a sort of cascade of degenerative changes. It often kicks off with the intervertebral discs.
The discs start it.
Yeah. They can lose height, bulge outwards, even collapse a bit. That straight away reduces the room inside the canal.
Okay, so the disc degenerate. What happens next?
Well, as the discs change, the facet joints, those small joints at the back connecting the vertebrae, they start taking more strain. This extra stress leads to osteoarthritis in those facet joints. The cartilage wears down, the joints themselves can get bigger hypertrophy, and they form those bone spurs, the osteophytes we mentioned.
Ah, the bone spurs again.
Exactly. And remember the ligaments?
Yeah, the ligamentum flavum.
Right. That one can thicken and sort of buckle inwards as part of this whole process. So picture this. You've got bulging discs pushing from the front, enlarged bony facet joints coming in from the sides and back, and this thickened ligamentum flavum also squeezing from the back.
It's getting crowded in there.
Very crowded. All these things combine to narrow the canal and compress the nerve roots of the cauda equina, that bundle of nerves at the end of the spinal cord. And that's what causes the symptoms. It's like a pincer movement on the nerves.
That paints a clear picture. Okay, so someone comes in with these symptoms, back pain, leg pain, worse on walking, better leaning forward. What else could be going on? What are the key differential diagnoses? Super important for exams, this bit.
Absolutely crucial. You've got to rule out other things. Herniated discs are high on the list, obviously, causing sciatica-like pain.
Yeah.
Spondylolisthesis, where one vertebra slips forward on another, that can also narrow the canal or binge nerves.
Okay.
Peripheral neuropathy, nerve damage outside the spine, can cause similar numbness and weakness, so you need to consider that. And of course, peripheral arterial disease, that vascular claudication we talked about. You need to check pulses and assess vascular risk.
Right. Vascular versus neurogenic claudication.
Exactly. And then there are the rarer but must not miss things. Spinal tumors, a really large central disc herniation, an epidural abscess, and critically cauda equina syndrome. Look for those red flags, bowel bladder changes, saddle anesthesia.
Okay, good list of differentials. Now, how common is this condition? What's the epidemiology look like?
Well, exact figures for the UK are a bit hard to pin down. But we know it's definitely more common as people get older, particularly over 60. If you look at spinal stenosis generally, estimates suggest maybe around 10% incidence overall.
10%. That seems quite high.
Yeah, but bear in mind, a lot of those cases found on scans might be mild or totally asymptomatic. The actual number of people with symptomatic lumbar stenosis is likely lower, but still pretty significant. There was a big study, the Framingham study in the US, which found anatomical narrowing on scans in quite a high percentage of older adults, even without symptoms.
So it might be there, but not causing problems for everyone.
Precisely. And with populations aging and MRI scans being used more often, we definitely expect to see diagnoses of symptomatic stenosis increasing.
Okay, a common and growing problem. So let's pull it all together clinically. How does it typically present? What are the classic clinical features we should look for?
The absolute classic presentation is that pain in the lower back, buttocks, or legs. But the killer clue, as we keep saying, is the positional nature.
The leaning forward thing.
Exactly. Pain gets worse with walking or standing for ages, basically anything that extends the lumbar spine. And it gets better with sitting, leaning forward like on a shopping trolley, that's a classic sign, or lying down.
Shopping trolley sign, okay.
Patients might also report numbness, tingling, weakness in the legs, and sometimes balance problems or difficulty walking. The specifics depend on exactly where and how bad the narrowing is.
You mentioned a specific syndrome.
Yes, the key syndrome is that buttock or lower limb pain. It might come with back pain, or sometimes the leg pain is the main thing. Remember the triggers: standing, walking, lumbar extension. And the relievers: forward bending, sitting, lying flat. Often it's a gradual thing. The leg pain, maybe numbness or weakness, creeps in after walking a certain distance. It can be one leg or both. And about half of patients also get that bilateral back pain, often felt over the buttocks.
Okay. And let's just nail down that neurogenic intermittent claudication again.
Yeah.
How does the patient describe it?
Right, neurogenic claudication. They'll talk about their legs feeling fatigued, weak, numb, or getting pins and needles when they walk. They often have to stop, sit down, or lean on something to get relief before they can carry on.
Not just stop walking, but change posture.
Exactly. The pain itself is often this burning or cramping feeling, usually in both legs, buttocks, thighs, calves, sometimes feet. And again, posture is everything. Worse leaning back, better leaning forward, sitting, or lying down. And here's that useful tip again. Cycling usually doesn't bring it on because you're leaning forward. That helps distinguish it from vascular claudication where any exertion causes pain.
That's a great clinical pearl. Anything else about relief?
Some find putting their feet up while sitting helps, or just lying flat on their back.
And what about the physical examination? What might we find?
This is where it can be a bit tricky. Often, the standard neurological exam checking power, sensation, reflexes is actually normal when the patient is resting.
Really? So the exam might be normal?
Yes. Quite often. The symptoms are typically brought on by activity or specific postures. However, it's absolutely vital to do a thorough vascular examination of the lower limbs, check pulses, capillary refill to rule out peripheral arterial disease causing vascular claudication.
So history is a king here, really focusing on those positional symptoms. Okay, what about investigations? How do we actually confirm it?
Imaging is key. You really need an MRI or a CT scan. These give you a direct look inside the spinal canal to see if it's narrowed, where it's narrowed, and by how much.
MRI or CT is one better.
MRI is generally preferred. It gives excellent detail of the soft tissues, the discs, nerves, ligaments without using radiation. Simple x-rays of the lumbar spine can be a useful starting point, though. They can show alignment, any instability like spondylolisthesis, and general degenerative changes like arthritis or loss of disc height. But they don't show the nerves or the canal narrowing directly.
Okay, so X-ray first maybe, then MRI.
That's a common approach. X-ray can give clues or spot other issues, but MRI is really the gold standard for visualizing the stenosis itself.
Any other tests sometimes used?
Occasionally, yes. Electromyography or EMG and nerve conduction studies might be done. These test how well the nerves are working. They can help assess the severity of nerve involvement, but they aren't always needed to make the diagnosis if the clinical picture and MRI fit. So, to sum up investigations, MRI is best for seeing the narrowing. X-ray is a decent initial look. CT myelography, where they inject dye, is an option if MRI can't be done, but it's more invasive.
Right, got the diagnostic pathway. Let's talk treatment. What are the management options for lumbar spinal stenosis?
Okay, management. The main goals are pretty straightforward. Relieve the symptoms, help the person function better in their daily life, and try to stop things getting worse. Broadly, treatment falls into two camps. Conservative, meaning non-surgical, and surgical.
Which route do you usually start with?
Generally, you start with conservative measures unless there are red flags or very severe, rapidly worsening symptoms.
Okay, so what does conservative management involve?
A few things. Physical therapy is really important exercises to strengthen the core and back muscles, improve flexibility, work on posture. Pain relief medication, like NSAIDs, can help manage the pain and any inflammation. Epidural steroid injections are another option. Corticosteroids injected near the nerves can reduce inflammation and provide pain relief, sometimes short-term, sometimes longer.
Steroid injections, right?
If someone's overweight, losing weight is often recommended to take some strain off the spine. And for that nerve-type pain, the burning, tingling medications specifically for neuropathic pain might be tried, like amitriptyline, gabapentin, or pregabalin.
Okay, a multi-pronged conservative approach. When does surgery come into the picture?
Surgery is usually reserved for patients whose symptoms are really impacting their life, causing significant disability, and who haven't gotten enough relief from a decent trial of those conservative treatments, say 3 to 6 months.
And what does surgery typically involve?
The main aim of surgery is decompression, basically, creating more space for the nerves. This usually involves removing some bone or ligament that's causing the narrowing, like a laminectomy. Now, sometimes surgeons also add spinal fusion, where they join vertebrae together for stability. But the evidence is a bit shaky on whether adding fusion routinely gives better results than just decompression alone for typical stenosis. Nice guidance suggests decompression alone is often sufficient.
So decompression is the core surgical idea.
Yes. There are also newer, minimally invasive options like interspinous process spacer devices. These are little implants placed between vertebrae to help keep the space open. NICE suggests they might be an option for specific patients, particularly for that intermittent claudication, maybe offering short to medium-term benefit. But again, patient selection is key.
Okay, so conservative first, surgery if needed, focusing on decompression. What's the long-term outlook, the prognosis, and any complications to watch out for?
Prognosis really varies, depends on how bad the symptoms are to start with, the person's overall health, how they respond to treatment. Many people actually do quite well with non-surgical approaches and can manage their condition long-term.
That's encouraging.
It is, but it's also important to remember this is often a chronic condition. It can progress slowly over time, potential complications. Well, the main ones are persistent pain that limits activities, worsening neurological problems like progressive weakness or numbness, and just generally reduced mobility and quality of life. And while surgery can help, it has its own potential complications: infection, nerve injury, instability, the risks of anesthesia. So it's a balance. Regular follow-up and managing the condition appropriately are really important for the best outcome and minimizing problems.
You mentioned earlier about comparing conservative and surgical outcomes long-term. What's the bottom line there? Is one definitely better?
Yeah, it's interesting. Studies looking long-term, say 5 years or more, often find that about half the patients managed conservatively report no major limitations in their daily activities. So non-surgical can work well for many. Patients who have surgery often get faster symptom relief initially. But even years later, many might still have some level of ongoing pain or disability, maybe mild to moderate. The really crucial point, especially for revision, is that the evidence doesn't strongly show that one approach leads to significantly different long-term outcomes compared to the other for many patients.
That's a vital point. So perhaps surgery buys faster relief, but long-term function might end up similar for many.
That seems to be what a lot of the evidence suggests, yes. Patient selection and individual factors are really important in deciding the best path.
Okay, that really helps clarify the management picture. So let's try and summarize our deep dive into lumbar spinal stenosis.
Sure, so lumbar spinal stenosis. It's common, especially as we age. It's caused by narrowing of the spinal canal in the lower back. This compresses nerves, leading to those characteristic symptoms: lower back pain, buttock pain, leg pain, numbness, weakness. Critically, the symptoms are often positional worse with standing or walking, extension, better with sitting or leaning forward, flexion.
Right. The flexion favors stenosis point.
Exactly. Management aims to relieve symptoms and improve function. You start with conservative measures, physio, pain relief, maybe injections. Surgery, usually decompression, is an option if conservative treatment fails or symptoms are severe.
And long-term outcomes can be good with either approach for many patients.
That's right.
So a key takeaway for your MSRA revision has to be understanding that nuanced clinical presentation, especially the positional relief, and really focusing on differentiating it from other causes of leg pain, particularly vascular claudication. Getting that distinction right is crucial.
Absolutely. Nail the pathophysiology, the typical features, the key differences from mimics, and you'll be well placed to tackle questions on this.
Excellent. Well, for more fantastic revision resources, including practice questions and detailed notes to really cement your understanding for the MSRA, definitely check out pathomsra.com.
And don't forget freemsra.com for great free resources too.
Perfect. Until our next deep dive, keep up the focused revision.